program was actually a youth program. And that's important for us because we're kind of a little different than a lot of health clinics, as we started off first with prevention, and then we went into youth treatment for drug and alcohol abuse, and then we went into the clinic in 1999. So we're a little bit different. So that was our sort of our lowly beginning, and our great insight by our executive director to buy up all the local property and all the crack houses in the neighborhood, and we were able to finally get this new building in 2007. So we have quite a few services you can see: patient youth treatment and adult aftercare, children and adult mental health counseling, and of course the clinic, and also a lot of our prevention activities. Next slide, please. And really, this is kind of our adolescent. This is kind of the makes up a great deal of the work that we do is through STI is sort of brought to our attention because of our Native Project Adolescent Treatment Program. It's been ongoing now for many years, and it's a intensive outpatient, and we do children from 12 to 18. They're usually either voluntarily put in, they're put in by the court or some by the school or in their parents. We average anywhere from 15 to 25 youth per night and can enroll at any time. And they meet daily from 4 to 6 and also meet with a counselor each week. And so we have counselors that work with the patients. We have 5 different counselors that work with the youth, and so they get to know them all pretty well. And then we have an honors program. So if somebody's been successful in completing the program, we still encourage them on a weekly basis when they come in and meet. So next slide, please. And this is really kind of the basis of a lot of the work that we do with youth and with STIs, and it's the chemical dependency intake. So every youth that enters the program, and they do it on an annual basis as well. So if they haven't been able to complete their treatment in a year, they continually have do this type of assessment, and includes, of course, the biomedical conditions. And so that includes if they're sexually active or sharing needles or other high-risk behavior. And every youth is encouraged. Actually, I believe they're required to get a physical to do this program. And so that's really kind of a good door opening for us. So a lot of them maybe do not have a regular physician, so we're able to, or they have been attending Native Health. So we're able to actually see them in, kind of rock them across the building. We actually have 2 separate entrances, so if a youth is going to the treatment, the clinic people cannot see that person entering, and vice versa. So they actually get walked through the building, and they check in at the front desk, and they get seen by the provider. And so because we do the chemical dependency part of it, and the high-risk behaviors are such a part of that, or it becomes our providers, I think, are more sort of aware of that and sort of looking for that anytime they're dealing with any youth. Next slide. And this is, like I said, it's the same building. They can see, anytime they can see the providers. The provider does review the health history from I think most people have their health history, and it does ask for tobacco, drugs, and alcohol. And even if they circle no, the providers have told me that usually if they have a youth, anywhere from 12 and up, they will usually go over that with them a little more in depth and make sure that they didn't miss this. Some kids are more willing to talk when they're in the room with the provider by themselves. The youth can schedule if they're over a certain age here in the state, and can schedule to see and talk about the STIs if they have any questions. Also on their program, if their counselor notes that when they fill out their biomedical that they're engaging in risky behavior, they will talk to them and encourage them to get the physical and to actually talk to a provider about the STIs. And these are just something that the providers, I went and talked with our providers, and they said that they always will address the alcohol, drugs, and sexual behavior with the youth. It's just something that's part of their practice. And if age appropriate, if the health history indicates they're tested for sexually transmitted diseases, and encouraged to do that. And of course, they talk to the patients about Gardasil. The provider was interesting. What she noted was that It just seems, in her talking with boys and girls both, she talks about abstinence and safe sex, and the girls are less reluctant to talk about that, it seems, even though she is a woman provider. They just seem to say, oh, well, you know, I'm the only one that he's involved with, so I don't worry about this. But the boys, as soon as she talks, telling them, you know, you could get infections on your penis, that sort of thing, they get much more willing to address issues and to have the provider check and make sure that everything's okay with them if they engaged in risky behavior. I think the last slide I have is on really it's the pre-treatment program. They require for STI education every 12 weeks. So we have someone come in, usually it's a provider. I've had to do it before when the provider was not able to, and essentially you lead a discussion for an hour. And this is where you can do a little plug for the Health Institute and also for the Red Talon program, because they both have great pieces that we can put in PowerPoints of information for the kids in order to help sort of set up that discussion. And we use a PowerPoint usually, and usually, of course, photos are good sort of attention grabbers. And then the treatment staff then they ask questions there in front of both boys and girls, but then afterwards they divide the boys and girls to answer questions with the counselors, so they're able to answer more specific. This year we tried something new on December 1st on World AIDS Day, and we did a special session. We always do something on AIDS, but this time we are offering the HIV rapid test. And 5 out of the 8 youth that were there that night agreed to testing. As one said, it was the slowest 20 minutes he's ever been through. So I think they're very knowledgeable sort of about the sort of some of these areas, but in some areas they're not very knowledgeable. And some of the questions you get indicate that a lot of the information is coming from other peers or in some websites that maybe aren't very education-minded and are more sort of calling to attention some other myths. So I think that's really our biggest focus is through the treatment program. Every time we get a youth, however, in for a physical, it's definitely a part of our intake form, and we also have, of course, we have these GIPRA forms that we have to do, and so that does include a question on alcohol and drugs, and that is gone over by the provider as well as the health history the provider goes over with them. And a lot of times, as I said, even though they might answer no on alcohol and drugs on the paper, they actually will later come and say, well, yeah, I've tried this or whatever. Or and of course, we do have condoms that we used to get free, but now we order them from the different sources around, so the youth do have access to the condoms, and we keep them open in the treatment area, encourage them to take them if they're going to be involved in sexual activity. So I think a lot of it is different for us just because we started as a treatment program and it became such an issue and that it is part of their curriculum. So I think our whole medical part of it, our clinic, is really tuned to sort of concentrating on, when the youth do come in, concentrating on these issues. I also have to give a plug to Jesse and to the hepatitis program. They've done a great job of coming and helping us meet with our staff. We do have, we do the training yearly for the staff on hepatitis, and they've got a great training that they've done for us in the past, and it's an awesome thing. If you haven't utilized them, I'd certainly encourage you to. And I think that's all I have.
Thank you, Candy. I just have one question for you. How is this program funded?
Oh, you know, I have that on my notes that I didn't answer that in my slides, and I even have that on my note. Yes, we have a lot of what we do, of course, with the treatment program, they get funding through the county, through Spokane County, for a lot of the programs, and also if the kids are on Medicaid or whatever, or private insurance, we can fund some of our staff that way. But for instance, like the HIV, we just decided that was important enough that the clinic just ended up paying for that individually. Also, we do pay for one of our counselors through the 4-in-1 program that we have, and so one of our counselors is is involved in that, and so I'm very involved in trying to get information out to the youth on health education matters. And so we also utilize any of the other sources. So we do have some people that are paid through Indian Health Service under different programs, and maybe also through our third-party billing. We do a lot of third-party billing, so that's how we can provide the, for instance, the provider that usually comes over. She's from the Lakota tribe, and so she comes over and she does the training, and so she's funded mainly by third-party. So that's a lot of the funding that we get. We also take advantage anytime we can of getting any type of free material, anything. Certainly when they send out a lot of times the Red Talon program will send out programs, or you guys will send out information, and we certainly will utilize any of that information that we can.
Thank you. One last question. So what would you recommend to other sites to implement a similar service to the one that you're operating at Native Health?
If you don't have your own, I think if you don't have your own behavioral health program, I think that's a good place to start with a lot of these education. It just seems our behavioral health, whether they're adults or the youth behavioral health people, are very good about talking about a lot, very frankly, with a lot of these people, and are able to get in people that are engaged in risky behaviors but are not getting seen for these behaviors. And so that's a big place. If you don't have that in your clinic, then maybe making some partnership with a local mental health or whoever, behavioral health persons that maybe can do some referring to the clinic for you. We also have a prevention, we do a youth camp every year, and so this is always an issue that we talk about, at least briefly, about risky behaviors. And so anytime you can catch the youth in a program like that, I think it's helpful to talk about that. And we, like I said, it's kind of always on our mind because we do have that program.
Excellent. Thank you, Candy. Our next speaker is Dr. Geoff Booth, Medical Director at the Sacramento Native American Health Center. Dr. Booth is first going to give an overview of their hepatitis C service from screening to treatment. Dr. Booth?
Hi, everybody, and thanks for calling in and listening. I hope this will not be the second longest 20 minutes ever as far as hepatitis C education, but like what Candy had mentioned, we have found in our population that we have a tremendous number of people that have histories of both alcohol and or drug addiction, and have engaged in behaviors that are high risk, including methamphetamine use and intravenous drug use, which set them up to contract the hepatitis C virus. And so perhaps about a year and a half before I came here to the clinic to become the medical director, the previous medical director had set up and started a hepatitis C treatment program. And so I kind of had the experience of learning about hepatitis C in a very concentrated way. I had really known nothing about it other than it was kind of a bad thing to have, and probably a specialist ought to take a look at you if you do have it. And I was trained as an internist at UCLA, and ended up finding out that hepatitis C wasn't as big and scary as I thought it had been, and actually it turned out to be something that with a little bit of training and study and help from some of the people here treating hepatitis C in the community was something that we could continue to offer to our patients. Like I said, we do have a fairly large number of people who at some point in their life have engaged in high-risk behaviors that would predispose them to contracting the hepatitis C virus. And so as a result, for the most part, most of our patients upon entry into the clinic undergo a variety of screening labs where we'll check routine labs like chemistries and check for diabetes and these things. And in addition to HIV testing, which we do a lot of as well, we go ahead and do antibody testing for both hepatitis C as well as hepatitis A and B exposure in the past. And not surprisingly at all, we get a number of people that do have an antibody positive. Once we get that information, we know that the patient at some point has been exposed to the virus. And we also know that between 15 and 45% of patients tend to clear the virus on their own and don't need treatment. And therefore, our next test is often to get a hepatitis C viral load. Well, they'll check, the lab will actually go ahead and check and see if there's virus in the blood. And if there is a virus, we'll ask them to determine which kind of genotype there is. And for our purposes, we want to know which type of genotype. There are a number of different genotypes from 1 to 8, and genotype 1 being the most common, but also the different genotypes to dictate whether they're going to be on treatment for 6 months or a year potentially, and also some of the genotypes confer a better response to the medications as well. And so with that information, we then go ahead and refer the patients within our clinic to our hepatitis C treatment group and clinic. And so what we've done is we've set aside 1/2 day a week for hepatitis C patients. And there is an extensive kind of period of time where we actually take the time to get to know patients. We want to ensure that if they had been using drugs or drinking alcohol or even smoking marijuana for that matter, we'd like them to stop those behaviors for at least 6 months prior to treatment, because we do know that active drug use tends to make their ability to complete the treatment and go through the process much less. And then we also have a hepatitis C treatment group peer group that is held weekly on the same day of the clinic. And this is very, very helpful, because a lot of people, once they are given the diagnosis of hepatitis C, they really don't know what to do with all that information. And this is a forum where they can continue to get educational materials and learn about the disease process and how it affects the liver and their health, as well as to talk to other people that are in all phases of the treatment. So at any one given group, we will have people that have graduated from the program and actually have achieved a cure, people that are in the middle of treatment, or people that are just getting started and finding out what this is all about and whether they want treatment at this point or not, or what's kind of involved with the treatment and how to go about it. As far as treatment goes specifically, I oversee the treatment of all the patients that we have here at the clinic, and after extensive laboratory testing and imaging studies, which are all fairly easy to perform or order, we go ahead and make a decision to start them on the hepatitis C treatment drug protocol. And the mainstays of treatment have been interferon and ribavirin in combination. And over the last 6 months, the FDA has just recently approved 2 new drugs, Incivek and Victrellis, which are both protease inhibitors and have a high activity. They've been designed specifically for activity against the hepatitis C virus. And the early results that have come back show that these medicines are both very highly effective and increase the cure rates significantly in people with hepatitis C. And while they're not appropriate for the use in all strains of the hepatitis C virus, what we're seeing so far is very encouraging. And so once we made the decision to actually treat a patient for hepatitis C, then, excuse me, we go ahead and make a decision on which medications the patient will be on, and then we offer something that's fairly unique in the treatment realm, and that is directly observed therapy. In other words, with the interferon, that's an injection that's given once a week, and we perform those injections here at the clinic. And so most of our patients actually come in on a weekly basis to check in with the doctor, as well as to receive their shot and to go to the hepatitis C treatment group. And that helps us with a lot of things, because not only is the treatment prolonged upwards of 1 year in some cases, but the side effects can be pretty considerable depending on the type of patient you have. And so in order to keep an eye on them and see how they're doing clinically, this affords us a chance to go ahead and reassess them on a weekly basis to see if they're developing any side effects, or if anything happens that's significant, we can actually act on it and treat it or combat it in whatever way is appropriate. And therefore, we've had a really good success. It also is a great way to ensure compliance, because one of the things that we do know just about throughout all of medicine, but especially with this, is the more you take a medication, the more likely it is going to be to work. And so with us ensuring that the patients are getting their interferon once a week, and then continuing to discuss with them compliance about the other 1 or 2 oral medications that they will have to take at least twice a day, sometimes 3 times a day. This really shows that we have a good, we're able to convey to the patients the importance of staying on the treatment and to ensure compliance. And the results are really amazing. We've had a tremendous amount of success, and one of the nice byproducts, in addition to treating the actual virus and attaining a cure, really is that these patients will not end up having liver cancer. The progression to cirrhosis or the progression to liver failure is, for the most part, stopped, or at least very much slowed down. And so as a result, what ends up happening is these people don't go into liver failure as much, and they don't get put on transplant lists as often, and they don't die as often, which is a great thing too. But in addition to that is that I've seen over the period of weeks and months that we have these patients under our treatment, they become very excited about their health. This is something that they can grab onto in a very tangible and real sense. And it's been a vehicle to build their self-esteem, because they felt like, wow, I've gotten over my drug and alcohol problem, and I'm going through the hepatitis C program, and I'm having a lot of success with this. And they use that as a building block to engage in other behaviors that help them move ahead with their lives. And I've seen this happen time and time again, and it's very exciting to see the lights go on and to people really wake up and get passionate about the things that they're very interested in. And so it really has been a wonderful program overall, and it's been real rewarding. And, we are located in the heart of downtown Sacramento, and we actually have way more people than we can actually treat, and so there's always a kind of a line of people wanting to get into treatment. And I feel like we are actually reaching people and giving them hope for something that they've oftentimes been told in the past, that there's really nothing that they can actually do to get rid of this. And so we've been able to do a lot of things for people, and I think, from a professional standpoint, it's been very rewarding, and from a patient standpoint, I think they've also been very, very happy with the outcome. So I found that despite my initial trepidation and concern about treating what I perceived as a very difficult to treat illness, was actually well worth the time and effort that I put into learning about it and practicing it with my patients. And I think this is something that will continue to grow and develop in our clinic.
Dr. Booth, we have one question. Do all patients attend the Hep C group?
Yeah, We try to encourage everybody who is on treatment or who is interested in treatment go to the group, and we would like to see prospective patients go to at least half a dozen weekly meetings to make sure that this is something that they really want, because after all, we are looking at almost weekly visits to the clinic and tolerating the therapy that does have side effects that are sometimes significant. And so we want to make sure that the patients that we do start on treatment are going to be able to see it through to completion.
And then, Dr. Booth, as a last question, what recommendations would you make to other clinics that want to implement hepatitis C services similar to the ones that you provide at Sacramento Native American Health Center?
Sure, that's a great question. I think that the first thing to do would be to assess for the need, and by doing the simple screening, the antibody screening, and seeing how many people that you come up with that have the hepatitis C antibody, and then you can follow that up fairly easily with a viral load and genotype testing to see if they actually have the virus in their blood, and that'll give you an idea of how many patients that are that are in the clinic that have this problem, and then based on the need, I'm always available to talk and discuss about this, but there are a number of different liver and gastroenterology societies that have these treatment protocols and plans, and just getting involved with the literature and talking to people that do the treatment is also very beneficial.
Thank you, Dr. Booth. At this point in time, I would like to open up the floor for any of our callers who have any questions for our panelists today. You can either address them over your telephone, or if you feel comfortable, you can also put them in the chat box and we can ask them. So at this time, if anybody has any questions. Well, it sounds like we don't have any questions now. If somebody does think of a question that they'd like to ask, send it to me, UIHI admin, in the chat box, and then we can address that question later. But now I would like to turn the presentation over to my colleague, Jesse Folkman, who's going to go over with you about the new health promotion materials that have been developed at the Urban Indian Health Institute.
Thanks, Jim. Good afternoon, everyone. I just wanted to take a few minutes to let you know about some materials that we've been developing here at the Urban Indian Health Institute and that are scheduled to be released officially and go out later this month. So we want to make sure everyone keeps their eye out for these new materials. To give you kind of a sense of the goals behind these health promotion materials, we sought to develop the materials to address both viral hepatitis, HIV, AIDS, and STIs. So we're really looking to reach a broad spectrum of health topics and looking to reach ages 13 through 64, so also a broad range of ages. And really to develop materials that can be used to reach an urban American Indian and Alaska Native audience, and to create these materials that can be used by urban Indian health organizations in their clinics and their facilities, as well as other agencies that may find these materials useful in serving their patient population. Just to give you a quick overview of the process that we use to develop these materials, we began with doing a literature review to collect information on strategies and messaging that had been successful in the past with American Indian and Alaska Native communities. And we then worked with a local Native designer to develop some draft concepts for our messaging. We tested these concepts in the community during this past summer. And then since then, we've been working with the designer to revise materials to incorporate and reflect the community feedback we received. So right now we're in step 6, which is the final product. And This is a draft of the poster, the materials that we're putting together. We will have it available as a poster, an 18 by 24 dimension poster, and then also as a jumbo postcard, 5.5 by 7.5. So as I mentioned, we are scheduled to distribute these materials this month. Our distribution plan includes sending 5 copies of the poster and 100 copies of the postcard to each of the urban Indian health organizations. We'll be addressing these to the executive directors of the UIHO. So if anyone is on the call from a UIHO and has a suggestion of another recipient who we should address these materials to, please go ahead and let us know. Jim's email is included at the end of this presentation, so if you just shoot us a quick email, we'll make sure to get these materials to specific staff members if most appropriate. We will also be posting electronic copies of the materials on the Viral Hepatitis and STI Prevention project page. So these will be available for download both as the poster format and the postcard format. And then finally, we will maintain a limited supply here at the Urban Indian Health Institute for anybody who may need to request additional copies for your clinic, or if you didn't receive hard copies in the initial mailing, just go ahead and let us know, and we'll do our best to fill those requests that we receive.
All right, so at this time, again, we have one question for Dr. Booth. Are the costs of the group reimbursable by insurance, either private or Medicaid, Medicare?
The short answer is no. They are not. We have not set them up as a reimbursable cost. However, I believe that there is a possible way to do this. I'm just not exactly sure how to do that.
Okay. And then this is a question for both Dr. Booth and Candy Jackson. Are either of you aware of any evaluation reports or studies about the effectiveness of past STI education efforts interventions? And also for Jesse. For American Indians. So I think that's one of the goals of this project, is to do a literature review that we did for developing the posters.
Yeah, and there's a number of articles that talk about different messaging and intervention strategies. There isn't a lot that is specific to an urban American Indian and Alaska Native population, but there are articles more generally for American Indians and Alaska Natives.
And hopefully that answers that question. And if anybody wants to get a hold of us more, we will include our contact information at the close of this presentation. And then we'd like to open this up for any questions that anybody may have at this time. Again, you can either use your phones and just call it in, or you can chat it in and we can ask the questions ourselves. So if there are any questions. Well, we would like to thank everybody for participating in this call. This is my contact information. If you develop any questions you would like to ask later, or if you would like us to send you more information or learn how to get more of our materials, please feel free to give me a call at this number. I would like to thank you for being part of this presentation, and hope you all have a very good day. Thank you.
Thanks, Jim.